All right, we have one more speaker for this session. George Adams is going to talk about the latest data on Sirolimus-Eluting balloons. They like your talk before you gave it, George.
Perfect. Okay.
Figure out what my images jump in, but you'll see. You want to see display monitor there.
Okay. It's having a seizure. So I'm speaking on behalf of Marianne Brodman. I'm a little bit taller, not as good a looking, but I'm beside Eric right here, so I think I look pretty good. But regardless, they're trying to get my slides up right now. So I'll go ahead and start, then we'll get the slides. So, the Achilles heel of all vascular interventions has been restenosis, this inflammatory process that occurs. And to battle this restenotic effect, this cascade that occurs, these anti-neoproliferative agents have come to fruition. We've discussed paclitaxel in the past. So there's 3 current drug-coated balloons in the United States that are approved for the SFA. And then Katsanos had a series of papers that sort of tarnished that reputation. However, several physicians came to the forefront, looked at industry data, and have shown the exact opposite. Regardless, we saw this very similar in the coronary realm, where drug-eluting stents with paclitaxel used to play here in the U.S., but now don't because of acute stent thrombosis, and now sirolimus or limus agents are now the preferred strategy for coronary stents in the heart. In regards to drug-coated balloons in the periphery, we've seen a similar type of pattern, a similar type of story, and now sirolimus drug-coated balloons are coming to the forefront. I would love my slides, but regardless. So in regards to the sirolimus drug-coated balloons, what I'm going to be discussing today is solution. And what's interesting is that this is a drug-coated balloon that has 3 major components, right? Number 1, it has a limus. It has a biodegradable, dry-degradable polymer, which is in a microsphere, and it's a patented technology. And what it does is it allows the limus to more effectively get to the vessel wall, to the adventitia, where these smooth muscle cells are activated, number 1. And number 2 is there's a technology, the cell adherent technology that is also part of this balloon that actually keeps these micro reservoirs attached to the balloon, such that typically in the past, when you're delivering the balloon from the groin to wherever you're trying to go, you'll lose a lot of the drug getting to the locale. So the cell adherent technology allows these micro reservoirs to stay attached to the balloon, such that you don't have to use as much anti-neoproliferative agent, limus, and you get a higher concentration with a lower dose. Okay? There's been a whole host of studies that have been performed using this sirolimus, this solution drug-coated balloon, and I'd love to go through that data with you.
George, this is why they applauded before your talk.
Yeah. So, all right. So what's interesting about the data? So, they always say that if you don't have your slides, you learn what you need to know. There's a couple important things that you'll learn about the data. One is an above-the-knee study. It's the first-in-man study. Was 50 patients, and what it showed was that the late lumen loss was about 0.2 across the board. Okay, and so with this late lumen loss, remember that paclitaxel on average is 0.4, so it's about half, right, with this drug-coated balloon, number 1. Number 2 is, in terms of the target lesion restenosis, it was in the high 80s, and the primary patency was in the high 70s. So excellent results, and this was 6 months, and this was out to 2 years. The other thing that's interesting is that the TLR, in the first 6 months, you saw the majority of events occur in the first 6 months. And then out to a year and a half, it actually leveled off. There were no more events in the TLR. So that's the important thing out of the above-the-knee trial. In terms of the below-the-knee trial, what's also interesting, and I'm going to, so I'm going to jump through these just so you can have some visuals. All right, so this is the inflammatory cascade. This is just comparing limus to paclitaxel, which we all know, cytostatic versus cytotoxic. It's got a better safety profile, et cetera. This is the actual balloon. I've gone through the three pieces of the technology, the microreservoir, and then also the cell adherent technology. This is the enhanced drug delivery, just to show you, comparing two Taxus drug-coated balloons to the right versus solution. The amount of drug that's lost during the procedure when you're going through the sheath, et cetera, to get to the locale is less at 36%. Retained on balloon was more at 25%, and transferred to the vessel was more at 39%. This is another visual here, just showing you that to the left, the drug dose was less, okay, in terms of a 4x40 balloon and 6x150 balloon on the x-axis, comparing two Taxus drug-coated balloons versus a Limus drug-coated balloon. And in addition, even with less drug, you got more penetration of the drug to the vessel wall. So tissue drug concentration is higher in the first hour and goes out to 60 days. It actually goes out to 90 days, which is very interesting. So less drug and, again, more potency. In terms of the studies to date, I just talked to you a little bit about solution, the first in man. They've done their due diligence in terms of the SFA popliteal, below the knee, and a whole host of physician-initiated studies, again, looking at below the knee, SFA, and foot. In terms of the solution SFA first in man trial, again, 50 patients prospective, looking at this late lumen loss, which I discussed a second ago, and we'll get to that slide. Typical comorbidities, looking at the demographics, older population, about 70 years of age, male, typical demographics, hypertension, high cholesterol, about 25% of them were diabetic and end-stage renal disease. If you look at the lesion length, it was 64 millimeters plus or minus 42, so somewhere between 20 and 100 millimeters, okay? 64 being the average. 30% were occluded, and then as you can see here, moderate to severe calcification, it was about 46, 48%, depending on what my math shows me there. In terms of the late lumen loss, again, this is what's most impressive, so it's 0.2 millimeters. Going a little bit off tangent, we not only see this in the SFA, we see this below the knee at 0.2 millimeters, we also see it in the coronaries. That's not part of this talk, but in terms of the SFA, it was 0.2 millimeters. In terms of the trial analysis, it was safe, no death, major amputation out to 2 years. The target lesion restenosis, as you can see here to the right, and this is what I was remarking to earlier, out to 6 months, 12 months, you can see there's a leveling off out to 720 days. Most of the events occur early on in terms of TLR. In terms of there were clinical improvements in Rutherford classification. As you can see here to the left, ABIs, the middle slide, and walking impairment at 6 months, and there was further improvement out to 12 months, and then it leveled off at 24 months. In terms of the Prestige trial, this was the first experience treating TAS C and D lesions below the knee with the solution drug-coated balloon. As you can see here, this was a real-world population. 88% had diabetes, 40% with end-stage renal disease, 100% had Rutherford 5, moderate to severe or high risk considering the Wi-Fi score. As you can see over to the far right, there were 0 bailout stents. The anterior tibia was the most commonly treated vessel, and then 63.6% of the lesions had moderate to severe calcification. As you can see, technical success was 100%. The freedom from device or procedure-related mortality through 30 days was 100%. Freedom from target lesion revascularization, 93%. Amputation-free survival was high, 84%. Primary patency, 82%, and wound healing was 82%. Pretty impressive. At 18 months, we saw similar results, right? Freedom from target lesion restenosis, 88%. Amputation-free survival was high at 79%, and wound healing was high at 79%. As you can see here, these are always a little bit challenging. You have to spend a minute with it, but what this shows us, that 79% of the patients, about 80%, showed an improvement of at least one Rutherford classification with treatment of the solution drug-coated balloon out to 18 months. The other thing that we talk about, and we don't talk about it usually on the podium, but a lot of us see that there's some distal debris that goes, especially in the tibials. We see this slow flow a lot of times with paclitaxel drug-coated balloons, especially those ones that have a higher concentration. What's interesting is that we didn't see this slow flow phenomenon in the Prestige or the Pristine clinical trials. And maybe it was because of that encapsulation of these microspheres that they have on the balloon. Just a hypothesis. So in conclusion, you've heard this talk twice now, with and without slides. So the solution drug-eluting balloon is a novel cell-adherent technology with microreservoirs containing limus and a biodegradable polymer. Current data is promising above the knee and below the knee disease, and a randomized control data, and we are expected to enroll in both the above the knee and below the knee in June of this year. Thank you very much for your attention.